Bismillahirrahmanirrahim. This video is about miscellaneous tumors of the prostate. These are the references for this video. The miscellaneous tumors of the prostate can be studied under the heads of ductal adenocarcinoma, adenosquamous carcinoma, pure squamous cancer, adenoid basal cell tumors, colloid carcinoma, signet ring carcinoma, small cell or neuroendocrine carcinoma. Then there are variety of mesenchymal tumors from leiomyoma, solitary fibrous tumor, angiomyoma, and also the malignant counterpart of these mesenchymal tumor. Then there are tumors that metastasize to this area locally and from distant organs. Then there is a variety that is embryonal rhabdomyosarcoma, that is the most common type of the tumor in children and infant in the prostate. The prostate adenocarcinoma may arise in the prostate duct and termed as ductal adenocarcinoma. Its morphology may be similar to prostate carcinoma when arising in the prostate large duct, but it has got distinct morphology when arising in the periurethral duct, as the periurethral ducts are lined by transitional urothelium. This upper picture is the whole mount of the large duct adenocarcinoma. It is located in the center and has papillary configuration. Histologically, the large duct carcinoma may show a papillary or cribriform architecture. The this lower photomicrograph is showing a papillary architecture of the large duct carcinoma. The other variety of this ductal adenocarcinoma is periurethral duct carcinoma. This comprises about 2% of the prostate carcinoma and resembles urothelial carcinomas. They present with lower urinary tract symptoms and hematuria. These ductal carcinoma are associated with poor prognosis, hence their recognition is important. In this photomicrograph, the primary urothelial carcinoma of the prostate involving large suburethral prostate duct. This picture is closely resembling a urothelial carcinoma. It is important to differentiate this entity from tumor extension of the bladder or urethra. Adenosquamous carcinoma or pure squamous carcinoma may arise de novo, or they may result after anti-androgen therapy or hormonal therapy for the ordinary prostate carcinoma. Another tumor is adenoid basal cell tumor, that is also termed as adenoid cystic-like tumor or basal cell carcinoma. It is characterized by expansile pattern of growth, multinodularity, a cribriform architecture with luminal basal lamina-like material, a surrounding fibromyxoid stroma, the presence of squamous differentiation, and foci of basal cell hyperplasia. It should be differentiated from basal cell hyperplasia and cinar adenocarcinoma with cribriform pattern and basaloid carcinoma and true adenoid cystic carcinoma. The colloid carcinoma is the tumor that morphologically resembles mucinous carcinoma of the breast. There is lot of intracellular and extracellular mucin, and the tumor that exhibit these mucinous secretion in more than 25% of the tumor they fall in this category. Another variety is signet ring cell type, and this signet ring cell type is characterized by presence of intracellular accumulation of mucin that pushes the nucleus to one side. Another variety is the small cell carcinoma or neuroendocrine carcinoma. This is the most aggressive variant of the prostatic carcinoma, and it is rapidly fatal. It typically occur as a recurrent disease in the prostate cancer patient who have undergone anti-androgen therapy. There are presence of androgen and independent subclones with a neuroendocrine phenotype. So this picture is showing these Paneth cell-like appearance, the upper picture, and these cells are positive immunohistochemistry. On immunohistochemistry, these are positive for chromogranin. Embryonal rhabdomyosarcoma is the most common malignant prostatic tumor in infancy and childhood. It is firm, smooth enlargement of the prostate, and extraprostatic extension is also present. The tumor are very cellular, especially around blood vessels, and these hypercellular foci alternate with areas of myxoid or edematous change with foci of necrosis. Most of the tumor cells are small, varying in shape from round to oval to spindle in appearance. These gross pictures are showing the outer aspect and cut surface of the embryonal rhabdomyosarcoma of a prostate in a child. The cut surface is smooth, lobulated, glistening, and grey-white, while the tumor is well encapsulated. Benign lesions in the prostate are extremely rare. Cystadenoma is a large nodular mass, and it extends into the retroperitoneum and attached to the prostate by a small pedicle. Histologically, it is composed of gland and cysts that are lined by prostate-specific epithelium, and there is a hypocellular fibrous stroma. The leiomyoma can arise in this area also, but these leiomyoma should be differentiated from purely stromal growth in benign prostatic hyperplasia and proliferative lesion of the prostatic stroma. The proliferative lesion of the specialized prostatic stroma can be divided into two categories. One are the prostatic stromal proliferation of uncertain malignant potential, that is also termed as PSUM or STUM. These lesions have got a tendency to recur. The other group is the stromal sarcoma. The STUM has shown four histological patterns, and these range from scattered atypical stromal cell to lesion that form a pattern of growth that resembles to phylloides tumor of the breast. The stromal sarcoma, they show great cellularity, mitosis, necrosis, and stromal overgrowth. This picture is showing the stump or prostatic stromal proliferation of uncertain malignant potential. There are prominent stromal cells, but still there is no features of malignancy there. Stromal sarcoma is characterized by this overgrowth of these cells. There is atypia also, and there is crowding of these cells, and there is marked pleomorphism in these cells, both nuclear and cytoplasmic, and atypical mitosis and necrosis are also feature of this stroma. These stump, they exhibit features like phylloides tumor of the breast. Other tumors that are common in this area are other mesenchymal tumors that are common in this area are solitary fibrous tumor, other type of sarcoma such as leiomyosarcoma, synovial sarcoma, the pleomorphic rhabdomyosarcoma, angiosarcoma, fibrosarcoma, the malignant fibrous histiocytoma. GIST is also reported in this area. The malignant mixed tumor of salivary gland type, Wilms tumor, and yolk sac tumor, that is also named as endodermal sinus tumor, cystic epithelial tumor, stromal tumor, and malignant lymphoma. All these type of tumors can arise in this prostate. This photomicrograph is showing an angiosarcoma with epithelioid features involving the prostate. There is vacuolization within the cytoplasm, but obviously the diagnostic confirmation is through immunohistochemistry. So these type of the area where these mononuclear cells are accumulated can be misinterpreted by an inexperienced pathologist as chronic prostatitis, but actually this is infiltration of the prostate stroma by the cells of CLL, and this can be an incidental finding during an biopsy interpretation for benign prostate hyperplasia. So the tumor to this prostate that are secondary can come to this area by direct extension or through distant metastasis. They come from the carcinoma of the bladder and urethra and have got two patterns. One is the infiltrative one. They can simply infiltrate the tissue, or they come to the prostate through extension of the primary tumor in the bladder and the urethra. They come to the prostate from colorectum and anus and soft tissue tumor. The distant metastasis may come from lung carcinoma, melanoma, and renal cell carcinoma.